Perfect. Thank you, Matthew. So we are going to talk all things compliance today, from the 2022 final rule to getting into the documentation conversation and how important it is to have kind of a good auditing process in place. So with that said, the title is Big Changes in Compliance, What You Need to Know for 2022 to Become More Profitable Despite Reimbursement Cuts. So guys, it's not all bad news. We have some good news and some good strategies that we're going to be talking through today. And we're going to be talking with Mr. Daniel Hirsch, who is a MEG partner and, you know, all things compliance. I go to him. He is my right-hand man. If there is any question that I'm just not quite sure of, he's the guy that's going to know all those answers. So very valuable asset to our team here at MEG. And I would also like to introduce you to Mr. Ravi Atreya, who is not only a medical doctor, but a PhD. So I was talking to him before. I'm like, probably now one of the smartest people I know. So he's going to talk a little bit about his company, PredictionHealth, and some of the solutions for this challenge of documentation that we all kind of are facing. So today's key discussion topics are the 2022 final rule. Daniel's going to spend some time unpacking what you need to know about that. I'm sure many of you have are familiar with some of these rule changes now, so we're going to just dissect it a bit more. And we're going to talk about the importance of having a compliance program in place for 2022. And then we're also going to talk about how to increase compliance through the use of AI. So we're going to solve for some of those documentation challenges. So welcome, gentlemen. I appreciate having you here today. We are going to offer a free compliance assessment for any of those that need it. So Matthew will put that link up on the screen. And then we'll also be offering a free compliance checklist. So please take advantage of that. That was developed by Daniel Hirsch. He has put that together for us to kind of do a checklist of anything that you have in place to kind of audit your compliance program. And then we will get kind of right into it because we have a lot of information to unpack here. And I want to start, Daniel, by asking you, why? Why do I need to have a compliance program? Sometimes I ask people like that I'm working with, do you have a compliance program in place? And I get the kind of like eye roll, like, do I really need that? Tell us, why is it important to have a compliance program in place?
Hey, Nicole, thanks for having me, of course. I hope Brian's doing well. I heard he's coming along nicely. Sorry he's not here. It's a great question when it comes to compliance programs. I think a lot of people, they take that backseat approach and they just think, you know what, it's not my marketing program. It's not my sales. It's not really, it's not getting people in the door. Why do I really need it? It's not so important. And the answer is, A, it's incredibly important, just like your insurance. So there's a lot of things that you need to do in order to open a business. And if you want to sleep at night, in my personal opinion, it's very important to have your policies in place to make sure that you are grounded and that you know what the regulations are for how it applies to your business. You worked really hard to get your license. I know I did. And it's really hard to maintain a business these days. So unless you just want to, run the risk and that's okay for some people, that's fine. But in the heavily regulated world that we are in right now, it's best to have something formal in place. A, it's required. B, it really helps dictate and structure your business. So it really grounds the business to have a resource to say, okay, well, what are the standards? What applies to me? And that's really the strength of what having a structured compliance program is.
So let's back up a couple steps because you said it was required. Is it mandated for everybody in every state to have a compliance program in place? And then what are those, like what is entailed in those requirements? Is that the checklist that you shared? What is it that encompass?
Perfect question, because I take the liberal approach. Not every single state actually requires it. So per se, I don't do everything that's required just because it's required. It's also often a really good thing to do. But federally speaking, from the OIG, we know from an enforcement standpoint, it's incredibly important to fines are dramatically reduced if you can prove that you have a meaningful program. And meaningful means not off the shelf. You take something, it collects dust. It's a compliance program that was built for, construction workers or something like that. It should be structured specifically for you. So depending on what state you're located in, really that's what dictates the regulatory. And everyone in my shoes will say the same exact thing. It always comes back to your state that you live in.
Okay, I think that's very good advice and good information. So let's kind of talk a bit about this 2022 final rule. Some of the highlights here. What are some of the changes with Medicare in terms of like deductible? Let's start there.
Sure. And before I begin, just want to mention, of course, a disclaimer. Obviously, I'm not an attorney, but the following information is not to be interpreted as legal advice. It should not be considered a representation of any company or individual practice. And really, you should consult an expert for specific and unique cases that apply to you. So please, I'm going to actually start with a surprise first topic that I wanted to bring up. It's called the No Surprise Act, which became law 2 years ago. It was in the interim final rule of October of 2021. And this does apply to outpatient private practices. So I just want to make sure that people are aware. It was kind of like a last second, people really were not paying attention to this. It went into effect exactly 13 days ago. And it requires a good faith estimate to be provided to someone without insurance. So the key point was the last few words I said. So you have to provide this information to anyone without insurance. So Medicare, or if they're private pay or something like that, this is not applicable. And the APTA, the private practice section, sent out a really nice reminder about this back in December. And you have to have the availability of this. That's the key thing to remember. So it's not as if you have to post your fee schedule. You don't have to do that. So it's not invasive in any way, but you do have to say, if someone wants this, how did they get it? That's the key thing to remember.
You do have to post it. Did I read that too? It has to.
That's correct. Yes. So anywhere that scheduling occurs, and that could be online, that could be at your front desk. So anywhere that someone schedules, this has to be available.
Okay. Yes. Good. Okay. So good information. So moving on to some of the changes with the 2022 final rule, what do we need to know? Like, what are some of the key points that we need to take away from this new rule?
Okay, so the key factors, again, I'm going to switch it up really quickly. I just want to remind everyone, this probably went unnoticed for a lot of you out there, but the M5 4.5 low back, I know Brian's probably thinking about this personally right now, that code is gone. So you cannot bill that anymore. Your EMR should have already implemented this change. So I just want to remind everybody, can't use that anymore. There's a more specific code, M54.51. So please, in terms of the rule that changed, the final rule for 2022, we have the Medicare therapy threshold, but not the cap, right? We don't call it the cap anymore, but that ticked up higher. Of course, it usually does to 2150. And that applies to PTs as well as the own and speech therapists. And then, of course, OTs get their own. The KX modifier gets applied to that. So that modifier is attesting to the fact that one is still medically necessary. So again, back in the day, we used to get all worried. Therapists used to ask me all the time, do I have to discharge my patients because they're getting to this magical number? And the answer is no. As long as they're medically appropriate for therapy, they should be getting treatment and apply this modifier. There's the same $3,000 targeted medical review. This may sound strange, but I tell people, please don't focus on this. Don't discharge a qualified patient, appropriate patient because of this. The cap is gone and it's been gone for a few years. So
yeah, but it's almost like you can get in trouble for prematurely discharging on a regular basis, right? Like this, it's something that you have to be, cautious with both ways, I would say. So do what's appropriate.
It goes right back to your first comment about having a compliance program. If you're doing something on a routine basis that should not be done, that's the whole point. So if you're discharging patients on a routine basis, you're kicking them out just because of a dollar threshold, that is not appropriate.
Yeah. Okay. And just making sure, of course, that your documentation is supporting what you're doing and why you're doing, and not choosing KX modifiers just to keep them there, 3 times a week for forever. So, right.
I love the KX, but exactly, if they're medically appropriate. From a telehealth standpoint, 2022, we're still good. So please, if you need to use it at your disposal. Every state, obviously, they have the final say. We learned that last year, that the state practice acts really, they dictate. Medicare allows it, of course, from a federal standpoint, but the states have the final say since COVID is still impacting everyone. And it's very likely that this extension will continue to be an appropriate line of service for us.
What is the date now that it's been extended to? Because I know it's been extended a couple times. Okay, so we are good for the entire year of 2022 to deliver telehealth services as long as it's in line with your state practice act.
Exactly.
Under this, temporary order. Okay.
You got it.
Yep. One question that I have on that topic that has come up is am I okay to do initial evaluations via telehealth, or does the initial evaluation have to be in person and then the follow-up care can be telehealth?
It's a good question. You're allowed to. The only caution I would always say is it appropriate? Provide the services that are appropriate for telehealth. There's a lot of training that you can do online now to educate your staff on how to provide telehealth through a meaningful use. Obviously, you're not doing manual therapy, so don't bill 97140. Of course, if you're doing telehealth. So in that regard, yes, if it's appropriate, you can do an eval.
Yeah, and guys, I just want to add a little bit of, just because I was doing a practice assessment the other day, and I asked, because their cancellation rate was at an all-time high due to COVID, not necessarily COVID positive, but COVID exposures. And, the topic came up. I'm like, well, are you doing telehealth? And kind of, the general answer that I hear a lot lately is, oh, we did a lot of that in 2020, but we're not really using that now. And I honestly think it is an awesome tool to be able to utilize and to think outside the box as a therapist. So just to kind of add a little value from that therapist perspective, we can see people actually, in their environment and take them through exercises or things in their environment, or look at their ergonomic workstation setup, because so many people work from home. So we can really use this as an advantage. So educating, yourselves, your staff, to know how to take advantage of the fact that now we can, offer this service and, help people in a different way, I think is just really valuable. Agreed?
It's a great tool for a workflow management, especially when people are canceling, possibly due to bad weather.
Yeah.
You name it. If you're not doing this in your practice, you have to ask why.
Yeah. And so tell me, because I know the CDC guidelines keep changing on a very regular basis, but can you kind of fill us in on the latest information? Because, people are kind of having to navigate through this, especially as we're having this surge happen. How do we handle those cancellation calls that say, I might have had an exposure? How do we kind of, unpack what to do?
So your guess is, no, I'm kidding. It's confusing. It changes almost daily. It's a big challenge. And there's a lot of information out there. So it's always dangerous when there's a ton of information out there, because people are going to be telling you what the rules are. And that's also risky. So my approach is take it on a one-on-one basis. So if there is a situation, don't apply a blanket answer. And you have to assess appropriately is risk management. So you have to say, okay, well, what's the exposure? What did that exposure look like? Yeah. Just remember, there were illnesses before COVID. So there should still be something in place where you need to protect your staff, the health of your clinic, the health of your patients. We're still wearing masks in most places. Sure. So from a 5-day versus a 10-day, I typically advise that you defer the liability off to a physician. So if you want someone to come back into your clinic, to your safe space, you need to get that order from a physician. And if you get that's a great tool to have, because you're not taking that exposure onto yourself.
Okay, so Kathy just had a question come in. Under the CDC guidelines, we should stay under conventional return to work guidelines, not contingency, correct?
Right, and that's typically 5 days, right? But the clock starts and stops depending on the symptoms, depending on when the test occurred. So it's not a simple yes or no. So again, that's why I'm begging everyone out there to really defer, have that individual call their physician. It could be a verbal, right? We accept verbal orders as well. So really say, do you want to come back in? Yes. Wear the appropriate mask, and then come back into the clinic if you have verbal orders from your physician.
Okay, good. And we are going to get into the PTA topic, but Kathy has a question. Maybe that'll be a nice segue into talking about the CQ modifier, CO and CQ modifiers. So maybe Daniel is going to hit on this, but can a PTA go to a patient's home under Med B? I thought that was allowed in 2021 and extended into 2022.
Yes, absolutely.
Yeah, and I think that falls under the supervision with the two-way, audio, video communication, correct?
That was my next topic. You got it. Yeah.
Do it. Go for it, Daniel.
So the outpatient practices, they've been targeted by CMS, right? Because they have a higher standard. If you're subacute so you don't have that direct supervision requirement. We do, which is on site. Versus the nonprofit practice, which is just general supervision. But because we're in the public health emergency, the direct supervision it includes a virtual presence through the use of interactive telecommunications. So as long as you're doing that, which basically means if that individual is not available, right, they're on vacation, then that doesn't qualify. But if they are available through the use of some technology, telecommunications, then that direct supervision is more lenient, which is good in my opinion.
Right. And so that's the important key here is it has to be accessible. You don't have to have it running the entire time. They just have to be accessible through, FaceTime or whatever you're using. Correct?
Exactly.
Okay, good. So let's talk about the assistant modifiers and the real yucky part about this conversation, those nasty reimbursement cuts.
You mean the insult to therapists?
Yes, exactly. Right.
We can't get any respect. The CQ/CO modifiers, this has been a freight train coming for years, right? Since we've known about this for at least 3 years, that this has been happening, kind of thought it would get pushed off. And last final seconds, there were a couple language discrepancies that were clarified. So basically what happened was in the bipartisan budget act of whatever, this is really the best way to think of this from a visual is that you're discounting your service. I'm thinking, what would Brian say? He said, you're giving a discount to your patients when a PTA or an OTA provides a service. So you're writing a check for 15% less. It's kind of 12%, but technically it's 15% off when a PTA or an OTA provides a service to a Medicare beneficiary. There's also a couple other insurances that apply this rule.
What I was going to say. They're just Medicare.
Right. But you got to calculate the math. But Nicole, what I want most people to understand is that in private practice therapy clinics, most of the time, 99% of the time, when a PTA treats a patient, each CPT code that they're billing the services for, they just get the modifier. It's that simple. Because we don't, and I'm speaking from experience as a therapist, but also in private practice, we typically don't have emergency situations where we're co-treating, providing the same exact service on the same date. That's typically not how we operate in private practice. So unless you're doing that, you really don't need to do, algebra 2.
I'm telling you right now, it is like mathematical gymnastics to try and decipher who gets this, the CQ here. So I agree with you, but I will say if there is like a specific, manual treatment technique that a therapist provides, and then the PTA provides, some other part of the treatment, that line item does get teased out and does not get the modifier attached. So just be mindful of that.
Yes, I'll give a couple examples right now, but what I really want people to think about as I'm talking is that if the therapist applies the treatment, the therapist is getting the code, right? So they're getting, each individual is getting their own code. And that was the nice thing about the final rule. So before it was all grouped together, and then you had to do the de minimis reason for 10% and all these other things. It was more confusing. Now, at least it's per line item. So if you do have to split, it's only splitting per code, which is, it's an easier math if you have to do the math. But bottom line is, if your PTA is doing the work, they're getting the modifier applied. It's really that simple. Does that make sense?
Yeah, no, that makes a whole lot of sense. And we're gonna spend a little more time taking a deeper dive into our mastermind coaching forum next week on, what do we do now about the PTA reimbursement cuts, and talk about some solutions there in our mastermind community. I don't want to spend too much time today because I do want to get through all of the rest of the information that we need to talk about, and then get over to Ravi in his presentation for Prediction Health. I do want to touch base on this question from Lindsay. Should the therapist be documenting something in their notes on why the PT is using telehealth?
No, absolutely not. There is a requirement for consent. So just be advised, you do need to obtain, it could be, some platforms that are popular. I know Brian has a few favorites. Yeah, they automatically provide consent. But you do want the individual therapist documenting that the patient consented, because there are other liabilities because of this service, depending on who's in the room and stuff like that.
Yeah, and we do have a good relationship with Marla Rainieri and BetterHealth. They do a great job. So we can throw up that link for you if it's something you're interested in reaching out to them about. Okay, so let's move on to the topic of remote therapeutic monitoring. What does that mean?
Great question. Just on the last example again, real quick, no other documentation is necessary. So I don't want people getting worried. PTAs don't have to worry. There's nothing else you have to do to justify the modifier. So good to go. So remote therapeutic monitoring, not to be confused with the 2020 remote patient monitoring, the RPMs, those aren't the same thing. So people like myself, when I first heard this, I got nervous. I was like, oh no, this again. Therapists were added last second. So I think that's why a lot of people were not aware of this. And there's 5 new codes that are allowed to be used by us, specifically physical therapists. The RTM codes, they're used for remote monitoring of a patient's health with an FDA approved device. So there's 5 codes. Generally speaking, there's only 3 that you'll probably practically use, which comes out to about, in my calculations, between $120 and $160 per episode of care. So, you'll find vendors that are saying, it's more like $250 or $230 that the dollar amount is. But generally speaking, there's really 3 codes that we could very easily justify the use for these codes. And the key is that you have to use a device in order to do this. Okay,
good. Let's jump over to the topic of dry needling, because I do feel like this is part of that 2020 final rule that's very like, oh, you got to read the fine print, because it looks like, hey, we finally are going to get paid for a service that a lot of PTs are rendering as a cash-based model, but what does it really say?
It's fantastic that each state has their own rules. I believe New Jersey, they're hot off the press. They're passing it again. 2 of the states that I'm licensed in, I'm allowed to perform dry needling. 2 of them, I'm not allowed to. It's per state. It's still considered, however, a non-covered service by Medicare.
Okay, good.
So providers need to collect cash for this service.
Yeah.
And there's 2 different codes for that.
Yeah, and I think my confusion was, or what I found was very tricky, is they allow for dry needling, but we're not listed as one of the, clinicians that could actually, providers that could actually.
We're not an approved provider, exactly.
Right. So like an acupuncturist could use that code, but not us.
Exactly. Yes. And that's just for Medicare. Exactly. Otherwise, you have to fall back on your state practice act.
Okay. All right. So and I think this is a good question. We kind of touched on this already, but given the elevated sense of focus on compliance, I want to spend a little time on that. Why? Why is this happening now? Because I've heard more and more people are getting audited, more and more people are, kind of coming under these reviews. Why is that happening now? What, in your opinion?
In my personal opinion, if you haven't been audited, you will be audited. In my opinion, they are fully funded, so the auditors are fully funded. They are out and about. Either if they're not walking into your door, you will be receiving a letter in the mail. So it could be disguised as a post-payment review or whatever they want to call it. It's an audit. So the idea is that they want their money back, in my opinion. That they have a budget issue right now, and they are trying to do everything as possible. They know the return on auditing services, right? They are fantastic at getting money back for every dollar spent, and actually trying to retrieve that money. So the idea is, if you're not prepared for it, that means it's going to just cost you a lot more when something actually happens. So that's not advice that I would ever give anyone, just to wing it and hope that they don't receive a letter in the mail or someone knocking, because West Coast, East Coast, it doesn't matter. Everyone I'm speaking to in the whole country, everyone's saying that they're getting audited.
You guys, you need the safety net. I remember we were in a meeting. I can't even remember what our meeting was on, but it was like a 10-minute meeting. And you're like, oh my goodness, like there's been 2 people that are getting audited like right now, as somebody walked in to their doors. So having a hit your hit moment, and having a Daniel Hirsch in your corner, which our compliance program does come with 2 hours of his time that he can help walk you through things, is an invaluable resource to have to help you navigate it. So that's my personal opinion. But I think that really is a nice segue into talking to Ravi here, because first of all, tell me a little bit about, what is Prediction Health? Tell us about your company and yourself and how you kind of got started.
Yeah, thanks. And thanks for the opportunity, Nicole, to be here. We got started actually going back to 2009. My co-founder and I went through the MD PhD program at Vanderbilt together, saw that documentation was a real burden for healthcare providers. And then we saw that the data that was being captured in those free text notes was also quite messy and difficult to work with. If you want to get some information out of it, it turned into a large data cleaning project. So coming out of that, we wanted to work on solving those problems. And we got exposed to the physical therapy space and found that they also had all of these compliance requirements about documentation. And so we found that we could take our AI training and apply it to the notes to be able to see and quantify what's in the documentation to help provide visibility across all of your documentation to know what your compliance status is and solve other kinds of challenges.
That's awesome. I would love to see a little bit of your data, and if you can share, I know we talked the other day, but some of the slides that you had, that would be awesome to walk our people through it.
Yeah, happy to share my screen here. And the thing, we got connected with Daniel, and he is the compliance expert. He's kind of been great in helping us develop this. And the thing we learned about kind of the workflow is, today, oftentimes a manual review, a manual audit of your charts to ensure you're compliant is often randomly selecting a small handful of charts each year. So you're getting visibility into less than 0.5% of your charts. Kind of with the AI that we've developed, we can get visibility into all of your charts. So that way you have you're able to track your performance over time and see if you have any weak points to quickly address those without having to do that kind of random sampling process.
Yeah, and I think some of the other key points, just as someone who trains on this part of implementing peer reviews into your therapist's performance, it just helps take that off their plate so they can focus on what they're there to focus on, and that's take care of patients. So I think this really does solve for a big issue within PT private practice.
Yeah, that's a fantastic point, because our goal is to make life easier for therapists and healthcare providers to do what they train to do, rather than dealing with all of the other elements.
Right. Very good. And I think, it brings up another topic of, and I know maybe you'll get into this, I don't mean to steal your thunder, but when you're doing peer reviews, there's a little bit of subjectivity mixed in, I would imagine, where, AI, it's very objective, right?
Exactly. We've heard stories that, hey, when you're doing a peer review process, if the folks are friends, give me your three best notes, three best episodes of care, and I'll review those. So you're not always getting kind of a realistic view of what's going on. And that way, now they can spend that time doing what they love to do instead of having to go through one more checklist.
Very good. All right. So how does it work? How does the AI work?
Yeah. So what our AI is able to do, and this is a simple example here, just to show you how we develop our predictions. We're able to go through and go sentence by sentence through a note, and we make predictions over 60 sentence types or so. And so as an example, we took the first sentence here from the subjective section: patient reports no new complaints. We predicted that is a negative signs and symptoms, HPI type of sentence. And here what you're seeing are the top three predictions, with the strength of the blue corresponding to the confidence of the prediction. And we're able to take that information across the note and combine it to generate things like checklists of what we found to be present in that note, and then things that we identified were missing, where perhaps you could add one or two more sentences to complete your requirements. And so we're able to take kind of these predictions and turn those into compliance dashboards, where you can get visibility again across each note that was written, to understand how your practice is performing. And so you can see here in this example dashboard that we have a number of therapists who are doing great. They have note audit scores that are 100%, kind of in the 90% range, doing really well. But you can also know where your effort needs to be focused on, kind of the therapists that might be struggling a little bit with their compliance. Kind of with this, you can look at it on the clinic basis, on a therapist basis, and we can start digging into other elements. So we can break it down by the type of note, whether it's an initial eval, a follow-up visit, a progress note. You can dig into other note types as well. So you can see, if you just wanted to focus on how's my initial evaluation performance, you can kind of dig in and zoom in right there. And then we're able to look at, you might see, hey, I have a therapist that's struggling, want to help. You can dig in on what is the gap, what specific things are they missing that might cause that lower note audit score. And so here is an example of an error rate, for example, for functional outcome tools, where we can look across therapists and see when they write their notes, how frequently are they not including that kind of information when we would have expected it to be present. And so here you can see a number of therapists are doing pretty well, but we do have a couple therapists who are are sometimes not including that information when they should. And so that's, an opportunity for improvement, and allows you to kind of get quick access to that kind of information. And kind of with these dashboards, you can also kind of zoom in and filter on different subjects, whether it's, the type of encounter. If you just want to look at follow-ups for, say, adult patients, you can do that. You can dig in on the type of problems. Maybe you're just looking at patients that come in with shoulder pain. Maybe you're looking at patients that are, post-op hip replacement. You get to zoom in on specific type of problems to see, get better visibility there.
Good. We do have a question, Ravi.
Yeah.
Does your product work with notes within various EMRs?
Yeah, so that's something that we're able to, one, easily do some chart exports initially to be able to run those through our system. For example, if you're able to export a PDF, we can run those through our system to generate these dashboards. And then we're also right now actually integrating with different EHR systems so we can automatically pull those charts out, so you don't have to.
Daniel, I gotta know, like, how much has this helped you and what you do for a living?
From a compliance standpoint, this is, in order to have full transparency, you'd have to have an army behind you to be able to do this. And, I wish I had this, 10 years ago. This really would have, I probably still have hair at that point. But
who needs
I
hair?
think that's really part of the challenge in compliance, where Ravi was showing that you could slice and dice this any way you want. If I just want to focus on low backs again, I'll pick on Brian. If you just want to see what the outcomes look like for that, you've never been able to extract text ever. That technology has never existed for us. So this is something really unique in that regard. So I think it's really fantastic that this does exist. And knowing where your exposure is from a liability perspective, that's incredibly valuable.
Yeah. And I think it's not just knowing where your exposure is, but also, and Ravi, correct me if I'm wrong, but your software helps to detect undercoding or, overuse of documentation where you're, having therapists that may spend a little too much time on that part of things, and therefore not doing, other productive work. So how could this be like a revenue capture?
Yeah, so great question. And we are able to, this is a little bit of a behind the scenes view here, so a little special behind the scenes view, but in terms of kind of the over documentation element of trying to identify if your therapists are actually documenting more than they need to in certain sections, where maybe they could kind of cut that back, save some time, and be more efficient with their day. We're actually looking in those 60 sentence types to build that note audit score. That final note audit score has about 20 or so components outlined here. We're actually able to, we've built a benchmark set of notes that we've validated to be compliant. And so we're actually able to, every time we get a new note in a new episode of care, we can compare it against that benchmark set, against those thresholds to validate, are they under documenting certain pieces of information, or are they over documenting certain pieces of information? And so we're able to track that. In this case, we have a lot of under documentation. It's because a lot of information in this episode of care was copy forwarded. So that's another thing that we're able to track, where a lot of grayed out text here is just copy forwarded text that we can also identify if that's an issue causing kind of the under documentation. So able to track both sides of that.
Yeah, so I think you just answered Punam's question of how do you establish minimum requirements for skilled need, and that's through all that benchmark data that you've collected and manually audited, right? Is that's gone through that process and then matched up against the AI?
Exactly. And that's a set that we're constantly developing and building,
Sure.
as well as we collect.
So it's going to get smarter.
Our notes, we're able to make it smarter and smarter over time, adapt to different use cases as rules change. We're able to handle those different scenarios.
Yeah, love that. And like we were talking about before we went live, anything that we can do to streamline our focus and automate our processes and minimize the, personnel involvement in things will just help that efficiency so much more. And it's not that it's not important, because it is absolutely an important part of what we do. But if we can use technology to assist us to become more efficient, then we can really focus on what we went to school to do, essentially.
Exactly. And it's been interesting as we've had a number of conversations now over the last few months here since we really started launching this product. The conversations of hearing folks that are spending 15 hours, 20 hours a month just reviewing charts. And that's time out of their day, it's time out of their family time, it's time out of their work time. We can give that time back.
I do have a question, especially for, and I saw some of our PEDS owners on here. What about the PEDS specific practice? Because I feel like the paperwork component is much more of a time, involved time, and a little bit more of a burden to the PEDS practices. How do you accommodate the PEDS practices, or how does your product?
Yeah, on that one, I might pass that one over to Daniel. As he's our expert on that front.
From a documentation standpoint, I get that question all the time, depending on the settings as well. But typically, when it comes to over documenting, or what we think as a PEDS trained therapist myself, it was very interesting that one assumes that there's more, different outcome tools that you're using. So the descriptions are different. That's true. But the categories, and Ravi, you could confirm if this is correct, my understanding of the system is that it's so smart that it knows there's subcategories of categories. So all this data is being collected, and it's able to fine tune is it there or is it not there? And that's kind of the magic where even a human has a very hard time doing that. And like you said, in a non-biased manner. So it's able to extract that what's documented and actually benchmark that in a meaningful way. So just from depending on what setting you're in versus what your demographic that you're treating to, ultimately it's still, are the categories still being checked off? Are you still complying with those requirements? And the answer is pretty simple. Is it there or is it not there? And that's how it actually gives a score, which is fantastic. It has all these scoring confidence scales, which is from a compliance standpoint, it's pure feedback and real education to the therapist. And just putting on an owner's hat for a second, you don't want to be wasting time really doing that for all your staff. You don't really want to have to sit down with them, go over this. This is real feedback and consistent feedback across the board to say, this is what you need to know, and this is how you can make an adjustment.
So what if you have a little bit of a not off the shelf private practice? What if your structure is a bit different and, you don't fit the typical, profile of an outpatient ortho PT facility? How does your software work with someone that looks different?
Yeah, for that scenario, we have our off-the-shelf kind of outpatient physical therapy benchmark setup. Mm-hmm. But then for different other cases, we can set those configuration settings on those thresholds to fit your use case. If you need to be a bit more stringent on a couple different measures, we can kind of work with you, can work with Meg and get those set up for you.
Okay, good. So there is customization available within your product.
Yeah.
Okay.
Yeah, we can kind of differentially set those thresholds to meet your needs.
Well, I think this is fantastic. Anything that makes our lives easier in a very complicated thing that we have to integrate into our workday. And it's always, I feel like this is I shouldn't say always, but it oftentimes will come up, documentation is always a sticking point. for a lot of owners. So people aren't getting their documentation done on time, things of that nature. So if we can really dial it in to what is needed and wanted per each episode, and not only, audit what we've done, but train our therapists to just make their time and use of their time much more efficient, I think it will just help all around. Okay.
Absolutely. And I'm happy to share a little update on this is a little preview of what's to come on some of the coding. Nicole, you asked about that. We are also now now that we're processing the text with our AI, we're also now looking at kind of the coding element as well, which is tied in to this too, where we can look at, for example, the minutes that were assigned to CPT codes relative to check-in and checkout times to look at time efficiency for therapists, where you can see that, we might have some therapists that there's a larger gap there where they're assigning minutes for, 30 minutes of time spent with the patient in CPT codes, but the difference in check-in to checkout time would say 60 minutes. It's an opportunity to dig in and identify what might be going wrong. And then we're also digging into billing efficiency, looking at the difference between total minutes assigned to CPT codes and the minutes that were actually billed for. To identify, again, we're seeing variability here between therapists, where you have some therapists where there's just a small 1% gap, which makes sense. And then you have some where there's a gap between 5 and 15%. And so we're working now, digging into those notes with our AI to identify kind of the differences between those cohorts of charts, to identify how we can help those therapists, again, that are struggling, how we can make it easy for them to perform with the other top performers in the practice.
Yeah, I love that, because then you have some objective data to go to your therapist and say, hey, listen, just as much as it's not appropriate to over code. Brian doesn't like me saying overbill, because we don't bill as therapists, but overcode, it's equally as inappropriate to undercode and unethical to undercode. So that, I think this is great. And it's a good, educational tool for especially your younger therapists just coming out, who are so scared about overcoding, to show them why they need to bill for the services or code for the services that they provide. I like it. Okay, so we have a question. Does this program also work for speech therapists and OT?
So we have processed some notes from kind of the OT and speech OT domain, and we can kind of again set up those configuration thresholds to meet your use case. Now, I personally have less experience in the speech therapy area. Daniel would be interested in your perspective there on how this could fit for that use case.
Yeah, from what I've seen, PT and OT definitely, and from a speech therapist, they do treat differently. So the notes are structured a bit different. So that, I believe, my understanding is, again, in outpatient therapy, that's usually the 1%, 2% of therapists in a clinic. So my understanding is that that's probably a work in progress right now, but I believe that's intended to occur.
So here's my question. When are we going to get it to write the notes for us?
That is something. So that was the origin of how we started the company, was going to build an AI scribe. And so we're working on it. So when that's ready to go, we'll come back and let you know.
An AI scribe. I like how that's framed too. I think that's good. So again, we just want to get the data on there. And so if the computer can do it, that's all the better. All right, excellent, Ravi. I'm super excited about this and in PredictionHealth. So you guys, if you have, if you have an interest, we did put the website up. Please reach out directly to Ravi if you have questions. Oh, Casey McNamara said AI scribe is already available. Oh, okay. Not sure. I don't know about it, but we'll have to check that out. One thing that I would like to end on is I'd like to leave our listeners with one piece of advice. So, Daniel, what is your one piece of advice in signing off today?
Other than listening to Brian, the one piece of advice that I would give that applies to everyone is really, if you don't know what you don't know, you're just exposing your company. And that's the only lane that I live in right now, which is, it's really good to have a resource. You started off by saying, you know, a guy, right? It's really good to have a resource. I have my resources. It's very good to fall back on someone that you can trust and a company that you can trust. So I think it doesn't have to be, you know, anyone in particular, but I'm just saying in life, even, it's good to have a trusted resource. And especially from a liability standpoint, this is from a regulatory standpoint, you don't want to get in trouble for things that you don't know. Right. So it used to be, you know, reckless disregard or just negligence. That was your defense. You could just say, I didn't know. It's not a defense anymore.
Yeah. Okay, Ravi.
Yeah. Basically, you know, really appreciate the opportunity to be here today. I did see one question, I guess first, any Meg discount for Prediction Health? For that one, you know, we're working with Meg right now on putting that together for you. So when you reach out, I think on the link there, let us know that you're with Meg, and we'll get that to you.
Appreciate that, Ravi. That's awesome. We like to take care of our people. Yeah, and I echo what these guys are both saying in terms of, you know, you need a safety net. Yeah, you work so hard, and I love what I think we've helped over 46 startups since 2022. You know, since COVID started, the pandemic started, and it's amazing. So I know all the hard work and sweat and tears and everything that goes into building what you've built. Protect yourselves, guys. You know, don't just let it be washed all away, and put yourself at risk. So if it's not, you know, our compliance program, then some compliance program, just ensure all the hard work that you have invested so much in. So thank you all for joining us today. I think it was a really great topic, and Ravi, I so appreciate your time. Daniel, as always, I appreciate your time and both of your information. These guys are a wealth of knowledge. Use them, lean on them as a resource, and thank you all. Hope you have a wonderful day.